Hello, welcome to today's recorded session. Murmur, as you know, is a platform for interventional cardiologists and surgeons, which recently surpassed 1,000 members. We are delighted to welcome Gilbert Tang, who's Surgical and Academic Director of Structural Heart Program, Mount Sinai, and Professor in the Department of Medicine and Cardiology at the Icahn School of Medicine at Mount Sinai. Dr. Tang is really one of the luminaries in the field of TAVR and has published extensively on TAVR in TAVR. Gilbert, welcome to Murmur. We're so excited to have you.
It's been a pleasure, and thank you very much for having me here.
We're very excited because you have published extensively, and recently I had the privilege of watching the videos that you shared on YouTube, on your YouTube channel. I really encourage everybody to go and see those videos. We will not rehash the information in there, but they are truly amazing, and they walk you step by step through how you think about doing TAV-in-TAV, in addition to what we have on the TAV-in-TAV app. I would say TAV-in-TAV is an endless field of study. It's one of my areas of interest. And rather than trying to be comprehensive today and cover all the possible variations, I would like to focus on what most people struggle with, which is short in tall or sapien in evolute, which is probably the most that we see. The TAV-in-TAV app is obviously wonderful. Everybody should start with that. People should look at Gilbert's lectures. I would like to really discuss areas that are more controversial, where people struggle. Gilbert, a lot of people ask me, how do you even measure these valves? Do you measure inside the frame? Do you measure mid-strut? Do you measure outside? How do we tackle that, and why do we tackle it that way?
Yeah, no, great question, Andre. I think the first point I'd like to make is that based on the Redo TAV app developed by Vinny Bapat and Miho Fukui, and also the standard publishing literature, they measured the midpoint of the frame. That's kind of been a standard measurement. However, we know that within the frame, there's the leaflets inside, and also the leaflets is a certain thickness, but that's normal tissue, right? We're doing all the bench studies. We know that with structural valve deterioration that there can be stenosis and the leaflet can be thickened, just like surgical valves. So what we did not account for when we do this measurement on CT is those thickness. So when we do what we call in vivo sizing on CT, you have a certain size and you oversize a little bit, but keep in mind that you're not going to be able to expand what you actually measure because of those leaflets are thickened and can actually occupy the space.
So do you handle this differently on, let's say, a valve that fails by aortic insufficiency versus a valve that fails by stenosis and has heavy calcifications?
Great question. So I think with regurgitation, we might tend to oversize a bit more to avoid a risk of migration. Now remember, in a short in tall combination, the evolute frame tapers in and then branches out. So if you don't oversize enough in an aortic regurgitation situation, your second valve, your short valve, is going to be like cone shape. And now, what we discussed in mitral valve, you remember, is that we want to flare out the ventricular side. So in systole, it pushes against like a caulking effect, so it doesn't go into the atrium. Now in aortic, it's the opposite. So if you have a cone-shaped valve in a short valve in the evolute, the diastolic force is what will push into the ventricle. So you want to be able to oversize enough to avoid that from happening, especially in aortic regurgitation. Stenosis, you have a little bit of give and take because you have a calcified thickened leaflet. You have a little bit of a stickiness to it. But I still would not undersize per se. And most of the time, I think we know that the evolute weighs at a certain dimensions, and in vivo sizing typically is pretty close to that. You would typically, let's say for a 23 evolute, you typically put a 20. But if it's PVL or AR, you put a 23 in with the understanding that you might be risking the movement. We can talk about that later on in the video. But with 26 and 29 evolute, typically we'll do a 23 sapien. But if it's PVL, if it's pure AR, you might want to go to a 26 in a 29 so that you don't avoid the risk of ventricular migration. That's what we need to worry about. But yeah, so that's kind of what I would say, how it differentiates between AS versus AR. If it's mixed AS AR, which can happen, we would look at the echo and see how thickened the leaflets are, and then appropriately we might actually still use a 23 and a 29 and 26 evolute, but we might add volume. So, and we would also post dilate more aggressively to make sure it stays put in place.
Yeah, and I think the adding volume part is something that I struggled with for a long time because until I talked to Vinny a few months ago, I did not realize that the valve-in-valve app cannot actually recommend that you add volume, right? Because they cannot deviate from the IFU. We all know that we add volume all the time. I think one of the indications, subtle indications in the valve-in-valve app is where they tell you that if you fracture a valve, you may need to put a bigger valve. But I think people are not really aware of the fact that you know the app cannot tell you add 2 cc's, 3 cc's, and that there's really no standardization for that. And I think that's part of the art of this, right? Do you put a 23 plus 2 cc's or do you put a 26? And how we deal with that, I don't think anybody really knows yet.
Right, and I think you need to oversize somewhat, and that's where it comes in that, you just asked the question earlier about the stand frame measurement. We measure the inner, but in reality it's a little narrower, so you will be more oversized. The question is that, you don't want to have a situation where you have a gap between the second valve and the first valve, and then that run the risk of migration because let's say the mechanism of PRAR. Because at the end of the day, when you inflate, the balloons will go against resistance. It's a semi-compliant balloon with the Edwards system against the radial strength and the recoil resistance of the stand frame of the evolute. So why we discussed earlier is that adding volume is not going to hurt necessarily, but it may prevent a later migration. Now, to the other question about, some people was concerned about central AR, right? Because, some papers had demonstrated if you overexpand or push at CC, at volume, you might end up having central AR. We have not found that to be the case because that was done on the bench and there was no resistance against in the frame, right? Now here in a native environment, you have the native leaflets in there, you have the evolute frame in there, you have the evolute valve leaflets in there. So there's a lot of substance and materials. So you'll never be adding volume and then suddenly you have an overexpanded SAPIEN 3 inside the evolute system. In fact, we've done some preliminary work on post-CT and all of them were actually more or less underexpanded rather than overexpanded. So we would never worry about adding volume and then cause central aortic regurgitation.
And when you talk about oversizing, you're using the same definitions as in the SAPIEN IFU, right? So you're going
Correct.
with the
That's
same
a
area.
very good point. That's a very good point. And so based on the in vivo CT sizing from Vinny's app or your own CT analysis, your sizing chart will be based on the manufacturer recommendations.
And the other thing that I struggle with personally, and I don't think that there's a good answer to this, but as you pointed out, the evolute frame is in the area that we're concerned about is kind of cone shape. How much anchoring do we need? Is it enough if we anchor at one node and then it flares out and the second node you're outside the range for that size SAPIEN valve? Do you look for anchoring at multiple nodes? How do you handle that?
Great point. So the app recommends averaging between 4 nodes. So for example, if you plan to go the outflow at 6, you need to calculate 3, 4, 5, 6 and average it out. But you should also look at the node 3, what the area looks like, and then all the way up to 6. And the higher you go, because of the waist, you're more likely to anchor across a larger zone. The challenge is that if you start node 4, you do average 1, 2, 3, 4. And if you have a deep implant, typically the valve conforms to native anatomy, can flare out significantly. So then you need to worry about if you're not going to oversize sufficiently within the bottom part of it, you might run the risk of having like a gap. And that's when we would be concerned about migration. And that's when you might have to think about, should I upsize the valve, let's say from a 23 to a 26 or 26 to 29, just so that you have enough contact with the frame. Again, the reason being is that in diastole, it's going in the aortic to ventricular direction in terms of push force, and you don't want the lack of sufficient contact to be the cause of the delayed migration. Not acute migration, but we had anecdotally heard stories about the next day or a few hours later, patient crashing on you because of what happened to the valve.
Yeah, I think that's a very good point, and I heard you mention that. So in my mind, that's the Gilbert rule. If you see a gap between the two frames, you should be worried. So I definitely follow that in my own practice. So how do if I put a 23 inside a 26, let's say a 23 Sapien inside a 26, um, a fully expanded 23 you would hope would reach a diameter of 23. Then you have about a millimeter of frame of the evolute on the outside. And then, as you pointed out, if you have calcium, that takes some extra space in between the frames. When you're measuring your valve to coronary distance, do you go by saying this is going to be a 23? Do you say this is going to be a 24 circle? What size do you use? Because it's kind of hard to know exactly what's going to happen once you deploy the Sapien.
Yeah, no, very great point. So there are two factors into this. One is the measurement itself, like you mentioned before. At least in my experience, we've never seen a 23 becomes a 24. In fact, usually becomes a more 22 or 21 or less. But there is a little bit of expansion of the evolute frame. So whatever you measure on CT is kind of the most conservative number. It's going to be likely less than that. And I mentioned it in my YouTube video. Just beware, that it might be less than you think. So even though the measurements might be just above the threshold, let's say 2 millimeters, but it might be less once expanded. So we won't account for that. Even if you do simulation, like using a dedicated software, it might not be able to predict accurately. That's number one. Number two is that we could not predict accurately where the valve will end up. Reason why I say that is that it's a balloon expandable valve, it's a short and tall combination. So when you start inflating, even at the best of hands, it would be not that predictable to control whether it's going to go up or go down. So imagine if it goes up and you have your wrist plane there, and you expand, you might end up occluding the coronary, which you otherwise didn't think that you would. Not because you didn't plan it properly, but because you couldn't control the movement of the valve as it gets deployed. That's why I recommended a very extremely slow deployment. Make sure there's no PVCs on your pacing. We typically ask our anesthesiologist colleague that be a long pacing run, prepare for resuscitated patient. Now, the opposite is that if the valve starts to move down, then it's a problem because you were sized based on a certain averaging. If you start move down, you're now losing the seal zone. So then the expansion is going to be very different in terms of your the estimated distance. So again, we tend to be err of the side of caution. If you're concerned about the coronary, protect them if necessary. If you have the expertise to do leaflet modification, by all means, do that. It's not easy for TAV-in-TAV, but certainly you should account for those uncertainties in place. And in terms of the actual deployment itself, for us, it's a free operator procedure. There's the first operator, second who control the position one, and then position two is the one deploy the valve. But in my mind, the more important team member is actually the one holding the wire. We've seen that with a short and tall combination, the first operator, when they adjust, it's a very coarse movement, meaning that it's not like a fine movement and fine adjustment because the frame sometimes locked into the tissue of the evolute valve, and if you adjust it by pulling back, you actually change into coaxiality rather than the actual height and adjustment. Whereas we found the wire movements a lot more responsive. Pushing the wire will bring the valve up, pulling the wire, bring the valve down a little bit, at least initially until the valve locked in with the evolute. So we actually sometimes even test it. So when we do once we cross to the intended target, we actually push and pull the wire just to see how much control we have before we actually commit to the testing and then deployment.
I think that's a great point, and I've had the same experience. When you're trying to pull or push on the valve, all you're doing is tilting it. You're not really moving it up and down, and then you could end up in bigger trouble with that. How about predilation? I heard in your videos you saying that you predilate the valves, which has always made me nervous. So tell me how you do that and why do you do it?
Yeah, so no, let's talk about the first point. You know, people ask, why do you need to dilate a short and tall combination? You have a balloon expandable platform. So we have two reasons. One, if it's the stenotic valve, it's sometimes very difficult to cross with your with the sapien system. And we all know that once your sapien system is in the body, it's very hard to take it out again if you can't cross. It's a struggle. It's not like you can just snare it in and other maneuvers. So by pre-dilating, and we're not talking about very aggressive pre-dilating, even just small enough for the valve to cross, just like if you have a heavy bicuspid or other situation, it just makes the procedure a little bit easier to follow through rather than having to troubleshoot. The other reason also is that sometimes these calcified valves or just really thickened leaflets, with the positioning, it can be very difficult to control as well if you don't pre-dilate, again, once you cross the valve. So that, again, make it easier for us to kind of adjust. So those are the two reasons why we would actually like to pre-dilate. Now, having said that, if it's like a pure AR situation, the leaflets are wide open, I don't think you need to pre-dilate. But so again, it goes back to the mechanism of failure that you need to look at.
And do you ever see wide open AI after the predilation where the patient will become hemodynamically unstable?
Great question. So we actually had a case last year where we chose not to do TAV-in-TAV because patient is all Jehovah's Witness, high comorbidities, and the right cornea was actually threatened, and we don't have ways to do leaflet modification because the misalignment. So we actually chose to just palliative VAV the patient with, with a balloon. And surprisingly, the gradient improved somewhat, and there was no acute AI, and the patient was doing well for at least a period of time until the valve stenotic again, and we chose to protect the right, and then went ahead and do the TAV-in-TAV. So we had not seen acute failure per se, but of course, every case is unique, and I can't say with a blanket statement that it will never happen. But having said that, the good news is that if you pre-dilate, just like we like the pre-fracture surgical valve, even with acute AR, we have the valve ready to go, and we just deploy. And we absolutely would ask our anesthesiologist colleague to be prepared for that situation. So one thing that we found effective is to just control pace the patient to unload the LV while you get the system into the patient and move forward.
Yeah, I have to confess, in preparing for today's phone call, I looked at all your publications in the last 5 years, and I don't know if you counted them. There's 207 of them on PubMed. And the one that you described in Journal Society of Cardiovascular Angiography and Intervention 2023 about predilate, I mean, basically doing a BAV in a evolute really blew my mind. I would have never considered doing that. In surgical valves where we have to pre-fracture, we've done the strategy where we actually put the valve in the body, we prep it in the descending thoracic aorta, and then we have a second balloon from the other side. We fracture, and then we're ready to just advance the valve. But obviously, that's for fracturing the surgical ring. How about post-dilation? Do you recommend post-dilation in all cases, or what do you do?
Yeah, so that's a great question. Now routinely in low surgical risk patient for native TAVR, we do post dilate. For the balloon expandable platform, we do what we call double tap, same volume, and you can see fluoroscopically expand and more. Not because of PVL, but actually for valve expansion. We know that now with literature out there, and even in the recent randomized trial from the Accurate ID trial, that you need to optimize the frame expansion for durability. In low risk young patient, we want the valve to last as long as possible, the first valve, so we can avoid a second valve. And so with routinely, whether it's balloon expandable or self-expanding, we actually like to post-dilate, just to achieve a better frame expansion. With the self-expanding platform, it's easier to see in the cuts overlap view because that's the short axis of the annulus. You can see how it's underexpanded. Because if you look at the regular free cuts of the LAOV, it looks more expanded, and you say, oh, it looks good. I don't have to do anything, especially let's say the bicuspid situation. And if you look at the other way, say, oh my goodness, it's like really scrunched up. So we think that could have an impact on durability. Now for TAV-in-TAV, we do like to do the same thing. For the two reasons that I described earlier. One is that you want to optimize the second frame because we don't know the durability for TAV-in-TAV. There's no data out there other than maybe 1 year registry-based data. But again, that is really just based on echocardiographic evidence. But more importantly, to my point earlier, we discussed that if you see a gap between the two frames, that's real concern about valve embolization. So you need to add volume to kind of pin it more aggressively so that you avoid that situation that you have a buyer's remorse that you think, oh, I just don't want to do too much now. And then, a day later or even hours later, you come to face the consequence of embolization. And obviously, in those cases, you really don't have any transcatheter option to bail out other than high risk surgery. So I think there's little downside of post dilating in especially if look doesn't look right on the frame. We like to do that again to kind of quote unquote confer the frame expansion of the second valve. And there is a phenomenon what I call the frame to frame leak, meaning that if you're not expanded properly second valve, there's a leakage between the first valve and the second valve. And so, it's hard to see because there's so much metal. And if you don't do TE, it's very actually hard to see. And so I think by doing that, you really try to expand and make contact with the frame and the leaflet tissue to minimize any kind of potential gaps.
So, I think to me the first paper that really talked about this in a benchtop setting and is the Miriam Akodad's paper. I think it was in 2021, obviously the Vancouver group and yourself have published a lot on benchtop models. One thing that I struggle with is even in that paper, when you're looking at 26 in 29 and 29 in 34, the outer diameters were never nominal. So the valves never reach full expansion. So if you're implanting a node 6, which most people would argue is ideal, would you ever use a 26 in a 29 or 29 in 34 for stenosis, or would you usually go smaller?
Yeah, so we go by CT in vivo sizing. We don't go by the benchtop, and I think even Vinny and his group acknowledged that. That's why he's developed the app that way. So, but you do need to oversize, even marginally. So, I think that's very important. The risk of upsizing in a stenotic situation, you got this phenomenon. We actually did a live case a couple of years ago where we're still learning the procedure, and we started node 4, node 5, and then when we expand, there was a watermelon seat, and then the valve completely dove ventricular. We didn't know about supporting of the wire back then. It was a 29 or 34, and really it just barely caught onto the inflow of the 34, and the 34 is implanted deeper. So we had to rescue with 26 and end up being perfect and no issue. So if you do think about upsizing, be very careful about the watermelon seating, because remember, once you inflate the balloon, the volume of the contrast and the saline, it goes to the path of least resistance. And it might not go to the path of least resistance at the outflow or inflow. There's not really a way to predict that. You can't preferentially go one way or the other. And if you're not careful, it can start to slip down, and then that will be really deep trouble. Or worse, if it goes up and you occlude the corner, remember, even though, like you said, the 26 doesn't go to 26, but it certainly has more radial force than, let's say, a 23. And if you're very borderline in your coronary clearance, you can certainly run the risk of a coronary obstruction.
Yeah, and I totally agree with you. And personally, I think if you're looking at a node 6 on a 34 that's 24 millimeters, putting a 29 in there, it's a lot of oversizing, and I would never expect the 29 to be fully expanded. So I think everybody has kind of moved to in vivo sizing, and I think the original data was probably not something that we would follow these days. So talking about node implants, I think everybody agrees if you can get away with node 6, that's ideal. Put a valve in node 6. It's the easiest, safest procedure. Node 5, we have some benchtop data from David Mayer's Eurointervention paper where they looked at degenerated explanted evolutes. We don't really have clinical data, as you pointed out. But again, looking at Akodad's 2022 paper, they said less than 50% leaflet overhang with node 5 implant. A lot of people do node 4 implant even in aortic stenosis. And in the original Akodad paper, that resulted in 90+% leaflet oversize. And we don't have good, as far as I'm aware, good benchtop data or clinical data for node 4 implant in aortic stenosis. What's your take on that? What do you think? How do we tackle that?
Yeah, no, I think in terms of we still don't know what the in vivo leaflet overhang extent looks like. Despite what Stephanie Seller's group in Vancouver have demonstrated that, the leaflet don't really drape down because they're stiff leaflets. I think the other concern is that, whether those leaflets will remain impinging open, you still, have issue with coronary flow. In our framework, I would say I agree with you. If the risk plane at node 6 is below both coronaries, you don't have to worry about. But if one coronary is below, then you have to make sure that coronary won't get compromised. And if both coronaries are below, then you make sure both coronary are not compromised. So we would start to move the implant a little bit lower, from 6 to 5 to 4. Now, having said that, some people may say, well, I want to preserve coronary access because there may be a LAD lesion I have to fix later. I may want to preferentially start a little deeper and then see. The reality, as I mentioned before, it doesn't work that way. We know that if you start 4 minutes to 5, or 5 and you go up to 6. So I would say don't do it because you want to preserve coronary access because, you think that you may need to treat the lesion down the road. If you need to treat the lesion, our philosophy, treat the lesion first because it's always going to be harder with 2 frames than 1. Plus the leaflet of the second valve, plus the leaflet of the first valve. So do what you need to do to fix the coronary first, treat the patient first, and rather than doing a theoretical assessment and implant because it's still an unpredictable procedure, and you don't want to jail yourself because you can't control the deployment, not because you intentionally, land in a certain position. But yeah, so we always assess the risk and even so, if you think you're safe, it's never safe because it's unpredictability. So again, whichever coronary is at risk, we would definitely wire and protect. And actually, and from an implantation standpoint, it's a great landmark to see, visually speaking, because when you start to deploy, if you start riding up, then you would drop the wire, so that maybe try to come down. The first operator may try to push in a little bit to bring it down. Before you commit to the full deployment because the wire is a perfect clearance landmark to know where not to go above.
Yeah, no, I think that's a great point. I think one of the things that I struggle with is again the lack of data, both benchtop and clinical. I think for Node 5 we have benchtop data. For Node 4, I understand that Vancouver is looking at Node 4, how safe that is. My part of my concern is that when you're looking at again the original papers on leaflet overhang, Node 4 gave you about 90% leaflet overhang, and that is with in vitro sizing, so 29 in 34 and 26 in 29. If in so many cases we go smaller with a Sapien, so that theoretically would result in bigger leaflet overhang. And again, the leaflet overhang, if their leaflets are pinned up, then they put your coronary at risk. If they're pinned down, if they stay down, then they potentially could create restenosis above the sapien frame. And it's kind of Pollyannish to think that they're going to sit at 45 degrees. So I think there's still a lot to learn, and we don't have all the answers yet.
Yeah, I think TE may help in terms of imaging. I think maybe that we should do more TEs in these cases. We do that at least in our center routinely because we can turn off the lungs and really just stop the ventilation completely to allow us to very much more accurate deployment. We don't have to worry about the patient suddenly take a big breath and then the valve move up and then now you're in deep trouble. So I think there's definitely more to learn. I agree with you.
Okay, and one thing that was fascinating to me in your videos was basically your description of how the sapien foreshortens. Everybody's used to foreshortening from the bottom. Would you talk about what your experience has been with foreshortening in valve-in-valve?
Yeah, I don't think we have the answer to that. We don't have a scientific answer, and in vivo behavior can be very different from in vitro behavior on the bench top. And what we've seen is that we've foreshortened even for short and short combination, forget about short and tall, that it foreshortened both sides, top and bottom, and depends on how it's locked in. We've seen it foreshorten from bottom to top. So I cannot give you a definitive answer saying that in all situations it will happen this way. I think you just have to be very systematically watch on the fluoroscopy when you deploy. We recommend you simulate the deployment so you better understand a better resolution, particularly let's say in obese patients that the image quality may be challenging to get. To be able to better understand the whole deployment sequence, how it behaves, because every case is different, and we can't really prescribe one way or the other.
The other thing that I struggle with, and I'm curious to hear your perspective as a surgeon, is if you see a 70-something-year-old patient whose first valve has failed after 5 years, let's say, um, that person would be expected to live another 5, 10 years. When do you pull the trigger on an explant and giving them a longer term option? And when do you say, we're going to put a second valve in and hope that we'll never have to do a third one?
Yeah, no, those are great point. I think it depends on mechanism of failure and whether you can adequately address the mechanism of failure. So, for example, if it's paravalvular leak due to very hostile calcium and native anatomy, doing a TAV in the post dilatation is not going to work. I can tell you that, especially a short and tall combination, because the night node just recoils. A short and tall combination is really the only option, and we have done that for high surgical risk patients. But if you don't think you can get a good seal and you may have left with residual PVL, the only real option is TAVR explant in that situation. In prosthetic AS and AR, I think if the patient can be done with redo TAVR, despite the unknown durability, it is a safer operation procedure, and we published our data on that in the multi-center fashion than TAVR explant. So I think most patients would agree that I want to take the less invasive option. And to be frank, yes, the patient might get older. You need to take two valves out, but taking two valves is not going to be different from taking the first valve out, because the first valve is what adheres to the native tissue. The second valve is not going to adhere anything. In fact, you can just crush it and just fish it out very quickly. That's why a failed TAV-in-TAV is actually a relatively easy operation to take the transcatheter out, because it's confined within the surgical frame. The surgical frame is actually protecting it against from adhering to the native tissue. So we really just have to worry about explanting the first index TAVR. And that's why, going back to the original point, you really want to optimize the frame expansion of the index TAVR so that you confer the longest durability possible for the patient, particularly they're younger and low risk, because the second valve in, we just don't have the data on any durability. But at the same time, we know that surgically to remove the second valve, it's straightforward because it's confined within the cage.
And talking about that, talking about the lifetime management, when you put the first valve in, can you talk to us about how you consider the fact that the patient may need a second valve? Do you, when I do a SAPIEN, for instance, if the patient may need a second valve, I'm very cognizant of not implanting at zero, let's say, if that would put the coronaries at risk with a second valve, or maybe using a smaller valve and overexpanding it rather than using a bigger valve that is going to be taller. Do you look at that? How do you do that when you put evolutes in? Do you look at the height of node 4, node 5, node 6? How do you do that?
Absolutely. So I think, now a younger low-risk patient, we talk about lifetime management and discussion about valve choice and redo TAVR. And actually, I'm sure same as you, that we get patients asking all the time, how long does this valve last? Can I get a second one in? What are my options later on? And so you need to be transparent. And so actually, we've done some simulation exercise and published some work in that regard. Just, straightforward simulation, nothing fancy, but to predict that if I land the valve at this step, what are my odds of having able to do a reintervention down the road? And so with Evolut, number one, you always want to say, as I mentioned before, do the best job you can with the first valve, because that is your first best shot. And also, we've seen some of the data showing that there are some hemodynamic benefit of the Evolut platform, over the balloon expandable platform, in particularly, in the risk of ppm and hemodynamic performance. So, but beyond that, yes, we will tell patients that certain anatomies may not be amenable to redo TAVR, and they will need to be prepared for potential surgery. We can't have a crystal ball to predict what technology down the road. And of course, now with Evolut, at least we can attempt commercial alignment to make leaflet multiplication possible to facilitate a second valve. But certainly, we would let the patient be aware of, given their anatomy, what the odds are. We always tell our patients that we can do very complex structural interventions, but we cannot change your underlying anatomy because it's not open heart surgery. So we need to keep that into context.
And since you mentioned open heart surgery, and since you're a surgeon, has your practice changed in terms of doing more root enlargement, root replacement, kind of preparing patients who you do a surgical valve implant for the possibility of TAVR down the road?
Yeah, I want to mention that yes, unfortunately, root enlargement is not commonly done because in the United States, the average volume of SAVR, first of all, is going down because of TAVR, but also it's less than 5 cases per surgeon per year, so very few, and so most surgeons are not comfortable with that because it is a more complex operation. But more importantly, if you do root enlargement to implant a larger valve, make sure it's large enough to accommodate the patient's BSA. And also make sure you enlarge the ascending aorta at the outflow of the surgical valve because that's what drives and determines the coronary flow after a TAV-in-TAV procedure to avoid coronary obstruction. So even though put a larger surgical valve in, but if your STJ is small, just like with a TAVR, you're going to run, by itself, you're going to run the risk of sinus sequestration and coronary obstruction when you put the second valve in. So that's why we're, advise the surgical community to consider that you need to enlarge the sinotubular junction in addition to the root to be able to accommodate the surgical valve. Now, the other thing that the caveat of the root enlargement is that valve fracture will be contraindicated after that because of the risk of root disruption. So make sure that if you put a larger surgical valve in, that is large enough to be able to avoid severe PPM down the road because fracture will not be possible.
It's interesting you say that because I've heard surgeons on both sides. Some people say, absolutely don't fracture after I've done a root enlargement. And I've heard people say, oh, once I've done a root enlargement, everything will be so fibrosed in that you can't damage it. So I'm always
It's
curious.
unpredictable. It's like TAV-in-TAV. We don't know which patients have more fibrosed tissue and which don't. We don't have a microscope, unfortunately, to say that. So we kind of, in general, just to, avoid any potential risk and as a word of caution, to say that, try not to fracture. Of course, you can, do it, and but we just don't know what the outcomes might be.
How about if you had a patient who has a relatively shallow root with, a large root, shallow sinuses, low sinotubular junction, but you could get in a large valve, and that you can get a 25 or 27 in there, but that patient will never have a TAV-in-TAV, a TAV-in-SAV option down the road because let's say the posts of the valve stick out through the sinotubular junction. Would you ever consider doing something more during surgery for that patient? Because they're not going to have patient prosthesis mismatch. They're getting a large surgical valve, but they won't have a TAVR option down the road.
No, great point. I mean, certainly, with TAV-in-SAV, you can do leaflet modification. I think that's because of the commissures already aligned. But yeah, no, I think when we close the aorta, it's not unreasonable to kind of maybe put a patch in there and extend that. It doesn't add too much of a surgical time. And so you can, usually rewarming at that point. So I don't think that adds additional risk to the operation, but certainly something to keep in mind. But also more importantly, if you put a large surgical valve in, don't cant the valve and affect the hemodynamics of the surgical valve. You don't want to fail early either, and that can potentially affect your ability to TAV-in-SAV later on because the valve is canted unintentionally and cause the hemodynamic performance. So I agree with you.
Yeah, no, it's interesting. I always tell people that the biggest benefit of TAVR has been that it's brought the heart team together and that where surgeons and cardiologists work together and talk to each other. So, as cardiologists, we're starting to learn more about different techniques for root enlargement, about the Bo-Yang's method and Nix and Manoogian and Kono and all that kind of stuff, which used to be Greek to us before, but certainly when you see a tilted valve, it makes your life very difficult when you have to put a TAVR in there.
Yeah,
And
that's right.
go ahead. So final question, DASI simulations. Do you use DASI? What's your perspective?
Well, yeah, so DASI is FDA approved. It's a simulation software that allows you to input, certain parameters in the images, and they can predict the likelihood of, coronary obstruction, so valve position or expansion. So we have not adopted that in our institution, but I know other centers have used it more routinely now because it's commercially available. But yeah, no, I think it's available to predict it. But at the end of the day, it's still prediction. I think you need to use clinical judgment, and we like to do aortic root angiogram, LAO cranial view, take the parallax out, and align the frame of the evolute valve to kind of really assess the coronary situation in terms of risk of obstruction. So based on that, we make a final determination. Just like in the native TAVR, if we're using, we're doing a native TAVR, we do a root shot, and you look at, whoa, that, left cuff looks very bulky and tall, we might run the risk of obstruction. We might actually just go ahead and protect it. And we never had a coronary obstruction as a result of that, and we never regretted not protecting it. So I think, yes, those software can be valuable, but still, I think you need to use clinical judgment.
Yeah, I always tell people that in my mind, coronary protection is kind of like rotablator. If you think about using it and you don't use it, you're going to regret it. So I think the risk of coronary protection is so low that, as you pointed out, it's if you think about it, might as well use it. Well, thank you so much. I really appreciate you doing this. Again, thank you for all the work you've done in the field. We're always learning together, so greatly appreciate you participating in this, and thank you again.
No, thank you very much. It's a pleasure to be here again, and thank you for sharing this opportunity to sharing my thoughts and perspective on this field. And still, we have lots to learn, and we need more data to better understand what's going on for our patients.
Thank you. Totally agree.